So, hello everybody, and thank you very much for being with us this afternoon. Today we're rebroadcasting a pre-recorded session. At that time, really, a lot of people liked it. We had about 300 people logging in, and I also heard a lot of positive comments, and some people had asked me to do this again. So here we go. So Dr. Peter Mains is in Boston, and he's has tremendous experience in endoscopic sinus surgery. Thank you. Give me just 1 second. That seems to happen quite often. I don't understand it why. Let me see 1 second. Bear with me for just a second. All right.
Very much. Let me go ahead and share my screen. If you could just stop sharing your screen.
Yes, I have. I share the audio. All right, go ahead, sir.
There we go. Okay.
Great. We see it.
Excellent. Okay, and let me just. There we go. All right. Thanks everyone for taking the time to attend. My name is Peter Manis. I'm an associate professor in the Division of Otolaryngology at the Yale School of Medicine. So great.
I apologize. Give me just 2 more seconds. I don't understand what's happening. Sorry about this.
From Connecticut. I'm a rhinologist. Today I'm going to talk about avoiding and managing complications in endoscopic sinus surgery.
This is a topic I actually really enjoy talking about. Not because I like complications, but because I think it's one of those things that are important but difficult to talk about. Nobody likes to talk about when things go bad. It takes a toll on you. It takes a toll on you emotionally. It takes a toll on you physically, in addition to the patient. But we can't forget how it affects the physician. No physician walks into an operating room saying, boy, I'm going to have a complication today. When it does, something has gone wrong. The plan has been deviated from in a way that was unexpected. And I think it's important to discuss these kinds of things amongst ourselves. So we always remember everyone will get a complication. It's going to happen. The important thing is, did you do what you needed to do to try and avoid that complication? And then did you manage it appropriately? And if those two things are met, I think you can look yourself in the mirror a lot better and say, you know what, I did what I could, and I'm doing the absolute best that I can. Okay. These are my disclosures. There's nothing relevant to the talk. My main goal with this talk is practicality. My hope is to give you tangible, practical items for you to take back to your practice that then you can say, yes, I'll implement this, or I can try this, or I'm doing this already. I think the thought about complications honestly starts before we even enter the operating room. We obtain informed consent on every patient that we operate on. And so this is our opportunity to discuss with the patient, what are some of the things that could go wrong? And when I think about some of the things that could go wrong in sinus surgery, this is the list that I have. Bleeding, numbness of the upper teeth, infection. You can read all these. It's quite extensive. And honestly, if you presented me with this list and said these could happen, I would probably run out the door. But I think it's important as you're having this discussion to put it in the context of how often does this happen? If this does happen, is it reversible? Some of the important ones I think that sometimes we overlook are numbness of the upper teeth, especially when performing a septoplasty as part of your endoscopic sinus surgery. I always want to mention that, and it really decreases on the amount of questions and concerns I get afterwards. And then the concept of need for further surgery. Obviously, we're not doing this with the intention of having something else, but I think it's important to always have the discussion that sinus surgery is not a cure for sinusitis. It's not a cure for sinusitis without polyps or with polyps. It's a tool in the management of it, and there is the potential that there may need to be some other surgeries down the road. Okay. Other important points, again, before this goes on, sorry. Thinking about bleeding. Bleeding is one of the big complications that we run into during sinus surgery. And so a careful preoperative evaluation can help prevent those issues later on. What does that involve? Well, carefully reviewing medications. Are they on anything that could potentially increase your bleeding during a sinus surgery, including some vitamin supplements? Past medical history, do they have any issues with bleeding? Does their family have any issues with bleeding? And then in polyp patients, if we use preoperative oral steroids, that can cause some shrinkage of the polyps and then lead to some degree of decreased bleeding. I always like to also think about vision. You know, this is one of the big things that we think about in sinus surgery. Stay away from the eye and stay away from the skull base. So preoperatively, I think it's important to perform a gross visual exam just to make sure you're not missing something that was there before you even started. I always blot the eye. I always blot the eyes prior to surgery. I'll just, kind of press on them because that gives me a sense of how tense they are. If I have a concern about an orbital hematoma, I want that baseline tactile sensation so that I know if it's different. And I always keep the eyes exposed to view during surgery. I'll use a little clear plastic tape. If the anesthesiologist tapes them with anything else, I take it off and put this on. I want to see those eyes. I want to see if there's any changes, and I want that visualization available immediately. The other important thing, obviously, before surgery is a review of your CT scan. And I feel like this happens a lot. I tend to review my CT scans at the time that I see the patient. I usually look at them the night before the surgery. And then I also look at them the day of the surgery, kind of right before we're going to proceed. And the general rule in my operating room is if you don't have a CT scan, we're not doing surgery that day. And I've had times when we've had trouble loading it. It's been on a disk and we couldn't get it up on our computer. And I've had a handful of unhappy patients when I've said, look, we are having technical problems. We cannot proceed. But for me, that's a safer way to work. And you can see, the picture on the left side of the screen, very different than the picture on the right. And I want to know that, and I want to have that information available to me immediately. When I'm looking at a CT scan, what are some of the landmarks that I'm looking at? Well, I'm looking at a bunch of different ones, and we'll talk about each of these. But this is really important in terms of my preoperative evaluation. And again, in terms of that concept of avoiding complications. If I can figure out what's the shape and integrity of the skull base, where's the anterior ethmoid, what does the orbit look like, is it intact, where is the uncinate process attaching, how high is that posterior ethmoid relative to that maxillary sinus, because I'm going to find that maxillary sinus first. So that's going to give me a sense as I build that 3D model in my head of where is my skull base. What's that sphenoid sinus look like? Where's the optic nerve? Where's the internal carotid? And then is there an anode cell present? So first thing, shape and integrity of the skull base. I'll look at this mostly in the coronal and the sagittal plane. And for me, this sagittal plane just gives me a nice view of what is that slope. Some patients have a much more significant slope. Some people are pretty flat. It's good to have that information in your head, again, as you're building that 3D model, so that you can then translate that into your actual operation. And again, looking at that, the height of the lateral lamella of the cribriform. This is the most likely place where you're going to get a CSF leak. And so it's important to know how far does this dip down. I'm not going to go through what the Keros classification is, but this is the concept that the Keros classification describes. How low is that lateral lamella? And the figure A is very different than figure C. And that's a different area that you're going to be operating in. So you need to be aware, how far does this dip down? As I said, that lateral lamella of the cribriform is the most common area where you can get a CSF leak. If you look at literature, you can get that in about 0.2 to 0.5%, okay? And interestingly enough, and iatrogenic, you know, us doing it is about 16% of cases of CSF rhinorrhea. That's a lot. That's a lot. Again, these areas, you know, the posterior ethmoid roof and the lateral lamella of the cribriform are the most likely. And it's why I'm always, when I'm teaching residents, I will always say to them, don't be medial, don't be medial, don't be medial. You do not need to be over there. And if you are going to be over there, you are going to at some point get into that lateral lamella of the cribriform. Now, this happens. It's happened to me. Okay. And that's, I always hesitate to say it's okay, because obviously we're frustrated. It shouldn't have happened, but it can happen, and it does happen. Then the most important thing becomes, how do you manage it? And I think the important thing is, if you notice it, fix it right away, okay? Do not sit on this. Do not try and shove something up there and say, oh, I think it will be fine. You need to fix it right away. And if you're not comfortable fixing it, that's okay. Then it just needs to be gotten into the hands of someone who is comfortable fixing it. So again, either fix that at the time of surgery, or transfer to someone if you feel uncomfortable doing that. So what do I do? If I get a small CSF leak in the lateral lamella of the cribriform or the posterior ethmoid roof, what do I do? Well, honestly, and this is not on the slide, the first thing I do is I go take a breath, you know, because I'm mad. I'm mad at myself. And that's not the time or the emotion the way I want to be operating. So take a minute and just remember that, okay, this happened. The worst thing I could do right now is make it worse. So chill out, relax, and then move on. First thing I'll do is take away the surrounding mucosa of the area. So I'll usually use a bipolar for that to decrease some of my bleeding. And there's a lot of different techniques for repair. I would not say that some of them that any are more correct than others. This is just me. For me, for small leaks, a small hole in that posterior ethmoid, a small hole in that lateral lamella of the cribriform, I'll take a free mucosal graft from the floor of the nasal cavity, usually from the other side, but it could be the same side that I was working on, and I'll put that as an overlay graft. And then I'll take Surgicel and make very, very tiny little balls and push it up against the graft to keep that graft in place. I like to start in the middle so that I can see that the edges of the graft haven't moved. Because if it starts to migrate, obviously that's when you're going to run into some problems. And again, that's for small leaks. For larger leaks, and again, these tend not to be iatrogenic, but just in general, I'll use a bunch of different stuff. My preferred method is to use some acellular dermis, and that comes in a variety of products. And then either a free or typically a pedicled mucosal graft, like a nasoseptal flap. And then I'll start making layers. I'll place Surgicel up against it. I'll put gel foam. I'll put gel film because it'll keep some of that packing separate so that if some of it comes out, the whole thing won't come out. And then more gel foam. Now, I think this is always a question in my mind. What do we do with these patients afterwards? Do we admit them? Do they get a lumbar drain? Do we call neurosurgery? Again, I'll tell you what I do. I do admit them. And for a couple different reasons. Number one, I've just violated their skull base. I do not feel comfortable sending them home at that point. I would like to watch them. I'm probably going to get a CT scan later that night. A lumbar drain? No, I don't routinely put in lumbar drains on these people because their problem isn't a pressure problem. Their problem is that the skull base was violated. So their pressure, really does not need to be decreased in order for that area to heal. And then consult neurosurgery. And this is one of those tough ones because when I have had this happen, the first thing the neurosurgeon says when they come into the room and they say, we need to put in a lumbar drain. And so I always need to say, no, let's not do that. This is not a pressure problem. Let's not, but I do consult neurosurgery. We have a good working relationship with our neurosurgeons. And I think it's important for them to be involved in case there is an issue. I would not feel right doing something like this and just saying, let's not involve them at all. Having them aware is certainly, it's certainly not a harm and it's potentially a benefit. So, how can we avoid the CSF leak? First of all, entering that basal lamella inferiorly, very important, okay? And I mentioned this earlier, looking on your CAT scan at the posterior ethmoid height relative to the maxillary sinus roof. You're gonna find that maxillary sinus pretty quickly. And if you have a sense of how high that posterior ethmoid is relative to that roof of the maxillary sinus, that's going to give you a visual cue, which I think is going to be very helpful. Obviously, looking at your CAT scan beforehand to figure out the height of your cribriform. The way I do sinus surgery is I'll find the skull base height at the sphenoid face and then go along the skull base in a retrograde fashion from posterior to anterior. That for me helps. It helps keep me safe. And I use a 0-degree scope initially as I'm going back to find that sphenoid, and then I'll do a 30-degree scope in that retrograde movement. Obviously, I always palpate behind structures before I take them out to make sure I have some room, and then never be medial during that ethmoid. And those things will help tremendously to avoid any kind of issue. All right. Anterior ethmoid artery. You can see this here. And typically it runs within the skull base, but obviously at times it does not, as exemplified by this CAT scan here and here and here. This is a nice cadaveric example of the anterior ethmoid artery. Again, just kind of shooting out. And you could see very easily how you could go through that as you were just trying to take down some additional partitions along the skull base. This was actually a video from my fellowship. It was not a fun day as we're kind of dissecting and I'm going along here, just biting. I'm going to get that last little bit and I'm just, oh, man, I didn't need that right then. And that thing's going pretty good. And again, I think this is one of those times to take a breath and stop. The funny thing about when this happened, I shouldn't say funny, I guess funny because it was all fine. This is right when the scrub nurse was doing a shift change for a lunch, like literally as that happened. I was like, that's it. Lunch is canceled. Give me 5 minutes. I need it. Now, you can see it going pretty well there. So then what I did is just took a pledge it. Okay, just to pledge it to kind of, I know I got to fix it, but I just got to slow it down for a second. Now, obviously, my biggest concern is retraction into the orbit. So as this is happening, I'm looking at the eye and I'm feeling the eye right then and there. Thankfully, in this case, that did not happen. Get that pledge it in there. And now you can see this area. Put a little bit of Surgicel on there. Again, just to slow it down a bit. I know I'm going to need to cauterize this area, but I got to get that bipolar in my hands. And in this case, I have a bayonet bipolar. There's other bipolars. There's endoscopic bipolars that you can use. But as you get on it, now I can see it a lot better. And I would use a bipolar here, not a monopolar, because you're right up against the skull base. And it's fixed. And that's it. And actually, the dissection looks reasonably good here. And it's dry, and it was clean, and I could see it well. And there were no orbital issues. Obviously, if there's an orbital issue, you do need to address that. But in this case, this is something, it can happen, and you can address it with just some bipolar cautery to that area. But what happens if you get into that area and you do get retraction into the orbit and you get a retrobulbar hematoma? Well, a couple of things. I think it depends where you are. So if you're in the operating room still, that's a good time for the canthotomy and cantholysis, and you can see really well. You could also consider just a medial orbital wall decompression at that point. I can tell you personally, I've had one of these as a faculty member. It was in the operating room. We did the canthotomy, we did the cantholysis. That didn't do it. So I actually ended up performing a endoscopic medial orbital wall decompression, which relieved the pressure of the eye. The idea of globe massage, that's fine. Obviously, you want to get out any packing if there is any. I don't typically put packing in sinus surgery patients, so that's tends not to be the answer. And then, some people will use Diamox or mannitol. I personally think the thing that you need to do is just act quickly and get this pressure off the eye. It's not immediate. I mean, they're not going to go blind in 5 minutes, but you do need to work expeditiously in order to ensure that their vision is safe. One of the questions I think that always comes up also is, do you call ophthalmology? At least in my institution, ophthalmology is not getting anywhere fast. So I'll call them, but I'm not going to wait for them in order to do this. Okay. So let's move slightly to intraoperative complications. We've sort of been talking about that a little bit, but we're also kind of talking about it in the context of reviewing CAT scans. Let's talk about some specific things that can happen intraoperatively as well. Bleeding. We've talked about some localized bleeding in terms of the anterior ethmoid artery. What's another big area? Well, the sphenopalatine. Just posterior to the maxillary sinus. If you start getting some significant bleeding from that area, you've probably involved the sphenopalatine artery or a branch of the sphenopalatine artery. Well, what's another one? Well, this posterior septal branch of the sphenopalatine artery. If you're doing a sphenoidotomy and you're lowering that face of the sphenoid and you encounter some brisk bleeding, that's likely the posterior septal branch of the sphenoidotomy, which is really typically that vessel that serves your nasoseptal flap. So that's localized bleeding. And those are the areas where they tend to be very focal. But what about those patients who they're just so oozy? There's just diffuse bleeding kind of everywhere. Well, what are some things that you can do to help try and avoid that? And then what do you do if it's just going on and you're not getting it to stop? Well, in terms of avoiding it, I do like to use injection. I inject with 1% lidocaine with 100,000 epinephrine. Some of my colleagues don't use that anymore. They feel that topical epinephrine does everything that they need. I personally have found I get better hemostasis when I inject. And so where do I inject? Well, I inject the lateral nasal wall at the middle turbinate attachment, as well as the posterior attachment of the middle turbinate. I used to do a greater palatine foramen injection. That I actually found did not seem to have much effect for me, so I have stopped doing that. So I take a 25 gauge needle on a 3 cc syringe and inject that anterior middle turbinate attachment. I then take a 22 gauge spinal needle and inject that posterior attachment of the middle turbinate. During the case, I do use 1 to 1,000 epinephrine. I color it. I color it with a fluorescein strip because it doesn't go away. I used to use a surgical marker to color it, but I found that it faded quite a bit, and I didn't like that. We do use IV anesthesia. If you look at the data is a little unclear on whether this helps. I think if you talk to people that do this and use it, they notice a difference. You really want to work with your anesthesiologist to try and keep your blood pressure and your heart rate under good control. Elevating the head helps, and if I'm dealing with this and my head is elevated, I try and get the head up even more. Obviously, you don't want to be tearing a bunch of mucosa and things like that because that will lead to some bleeding. And then, when all is said and done, if you are having a hard time visualizing, you might just need to stop. And I've done this. I've stopped the surgery because I could not see very well, and I've talked to the family and talked to the patient and said, look, this was the safest thing I could do. We'll come back another day. There's something going on here that's just not working. And it's really hard, I think, for us as surgeons to do that because we want to fix the problem. But sometimes this is truly necessary. All right, let's talk a little bit about the lamina. This is another important thing that you need to look at on your scan is really the shape and integrity of the lamina. Here's just an example of a CAT scan. You can see that lamina is pretty well intact. That's very different than this CAT scan. And I better know this because this will sure look like a bunch of polyps to me. And I'll start going after that, and that will cause some big problems. Another area it's important to keep in mind is your nasolacrimal duct. This is just an anatomic drawing showing your tear system, the lacrimal sac going into that nasolacrimal duct and where that is located, and you can actually see that here on your CAT scan. Sorry, I find when there is too much anterior dissection at that maxillary sinus, you can violate that nasolacrimal duct. I would argue that violating that nasolacrimal duct does not doom you to the patient having epiphora, because I think we actually probably injure it more than we think. But that could certainly be an issue. The area where I'll see this often, and honestly, it's on purpose, is in tumor surgery. And at that point, a lot of times we're doing a dacrocysterninostomy at the time of surgery in order to avoid the issue later on. So, how do we avoid these orbital complications? Well, these are just a couple kind of key things. First of all, I use angled scopes to visualize that natural maxillary ostium. I'll use a 70-degree scope actually to see it, and I do not dissect anterior to this. The other point that I've always kind of liked the description of is treating the lamina like the facial nerve. What do we do in facial nerve surgery, and ear surgery? We find that facial nerve. We identify it. Do the same thing with the lamina. Find it. If you know where it is, you will not get into it. It's flat. I also find it very helpful that when you get into that sphenoid, see where that optic nerve is, both on your CAT scan and in the patient, so that you aren't getting anywhere near that. And then I would argue this is the most important thing in avoiding the lamina propria. Stay low on your uncinectomy. If you get up too high, you can bite into that orbit. If you're low, you are not going to get into it. One of the other points I had mentioned is the uncinate process and seeing where that is. Well, why is that important? Well, the uncinate process can attach in a variety of different areas. It can attach to the lamina, it can attach to the middle turbinate, it can attach to the skull base. And knowing where that is will help you do a couple things. But most importantly, it'll help you take that whole uncinate off. Excuse me. Because if you don't get rid of that whole uncinate, you're going to create a dual ostia configuration, which I would argue is another complication. This is looking at a previous maxillary antrostomy with a 30-degree scope. And you can see actually that maxillary sinus looks really nice, but there's something going on up here. So let's go to a 70-degree scope. And with a much better view with that angled scope, you can now see there's a bridge of tissue sort of separating that natural ostium up here from that surgically created ostium. And what happens is you'll get mucus recirculation in here. And this is actually a very simple fix. You just got to take that down. You can do that in an office if you want. But this is one of the keys about getting that whole uncinate out. I would argue this is probably my primary reason for doing revision surgery on patients is they come to see me, they've had a previous surgery, and the whole uncinate has not been removed. And this is one of the issues they have. Excuse me. All right. Let's talk a little bit about some of the carotid artery, optic nerve, anode cell relationships. Again, I would argue, folks here know this, where these things lie, just adjacent to the sphenoid. Here's your optic chiasm here. And obviously here's your carotid canal. And obviously these are areas that can be dehiscent. So it's important to look at your CAT scan and look at those bony relationships and see, is there an anode cell? Because if there's an anode cell present, you want to know that because you might think you're in the sphenoid. You might not be in the sphenoid. This is a case, and I'm going to apologize slightly for the poor video quality, but it's what we got. This was a pituitary surgery that I was working on with one of our neurosurgeons. And the way that we have typically done our pituitary surgeries is I'll gain access, put in a scope, put it on a scope holder, and then the neurosurgeon will work. And that's kind of what we were doing here. And so the neurosurgeon is drilling. The video is a little off. And he's kind of going along. And we have this control room outside of our neurosurgical suites. And so I'm in there, and as I recall, I'm chatting with one of my residents, and we're looking at some scans of some things. And I'm sort of watching this, but not really because, he's just kind of opening things up. You can see he's got a pledget in there, kind of just trying to keep some of the blood away. And he's just drilling.
Tomorrow, I promise you. We'll use the
drilling. And then, oh, Jesus.
That way I don't have to run wires
and now you see nothing. And I didn't see this. And what I hear now is I just hear my name being yelled. And I look at the screen and I see that picture basically. And so I run in and I know that there's been a complication. There's been a rather significant complication. So this is a carotid injury, and this is an iatrogenic carotid injury. So what did I do? Well, I got in there immediately and just packed. And I can honestly tell you I put 60 half-by-3s in this patient's nose in the span of no time at all. And then the bleeding was controlled. So she was not pouring out anywhere anymore. She said, okay. We got in what was described as an immediate angiography. Now, we're very lucky in that in our neurosurgery operating rooms, one of them is an angio suite. So we can do an angiography in the exact same room. It still took 45 minutes for the angiography to even start. So that was our version of immediate without even moving a patient. At that same point, what we did, we had actually harvested some fascia lata for the patient. So we had a leg incision. We harvested some muscle at that point as well. And that's what we were going to use for our plug. We then spent 90 minutes removing these 60 cottonoids one by one. And we had removed 59 of them, and we were still fine, and there was still no bleeding. And we got ready to remove the last one because we knew that that's what was holding things. So we had a scope and a suction in one nostril. We had a suction and the muscle plug in the other. And as that cottonoid was being removed, the muscle plug went right in. And then we started packing with some absorbable packing. That initial angiography did not show anything specific. And I think that's because we had packed it off essentially, so it did not show any significant extravasation. She did get a follow-up angiogram, which revealed the formation of a pseudoaneurysm there about 48 hours afterwards, which was then coiled. This patient did fine, which thank God. But that was a scary instance. But again, I think, the lessons that I took from that were a couple, actually. The first was we actually don't use a scope holder anymore. And the reason we don't use it is because we found that we lost some of that dynamic movement, which I think was helpful. And the second thing that we learned was, when faced with this, how do you fix it? I mean, this is one of the things that they'll talk about in courses and texts and things like that. Get some crushed muscle and put it in there, but it actually worked, which was encouraging. So, very scary instance with thankfully a good outcome. She had no neurological deficits. She had no issues afterwards. I have a couple other quick cases, and then I'm happy to take some questions. This is a case that was reported in the ophthalmology literature, and it came out of Hopkins. The patient was eventually transferred to Hopkins for care. Some of you might be familiar with it, but let me go through it a little bit. This is a 42-year-old gentleman who had chronic sinusitis. And during just sort of a routine endoscopic sinus surgery, the surgeon encountered, and this is the quote from the operative report, uncharacteristic appearing polyps from the right maxillary sinus. A microdebrider was then used to remove the polyps. And the polyps kind of kept going and going and going. And the case was eventually stopped when there was enophthalmos on the right noted. When this was found, the patient was then transferred to Johns Hopkins, who then explored the patient. And you can see the CT scan here in the bottom left. There was a defect in the right medial orbit, and there had been resection of the orbital fat, the extraocular muscles, and the posterior globe. And unfortunately, there's nothing one can do here. This cannot be fixed. This cannot be addressed. I think it brings up a couple important points that I have thought about when reading about this case. The first is, if something seems weird, maybe it is. So the idea of uncharacteristic polyps. What does that mean? That maybe should give us all some pause. And also, should we correlate that well with our CAT scan? Were there some polyps on the CAT scan? So that's one thing. The second thing, and I use microdebriders a lot, and so I would not say do not use a microdebrider. But again, I think as you're going farther and farther and you're chasing, you really have to kind of rethink, where am I going and what's going on, and is this the right instrument for that? The last thing that I would take from this case is bad stuff can happen. And what I mean by that is, the person who was doing this surgery, they weren't a bad surgeon. They were not a bad person. Again, they didn't wake up that day saying, I'm going to do this to somebody, and this is not something that was characteristic of them. They had a terrible complication, terrible for the patient and terrible for the physician. And so I just think it's also important just to remember some degree of empathy for yourself and for all of our colleagues. who are doing some very technical and very, very challenging work every single day. I don't present this to call anybody out. I feel for this patient a lot, and I feel for this physician a lot. This is another interesting case that actually, this is a patient that I met during my fellowship. The case has been written up. It involved a bunch of different people. This was a 45-year-old male who's a pilot. And he was a pilot for American Airlines. American Airlines based in Dallas. And he had what was thought to be at the time nasal polyps. Patient flew to Chicago and was actually getting his care in Chicago. And during the surgery, it was noted that actually these were not polyps. This was an encephalocele. And the encephalocele was repaired in the way that one would expect. It was bipolar cauterized, and the skull base defect was repaired. And, but it was definitely a different procedure than the patient had anticipated. So as they told the patient, look, you need to stay in the hospital. We need to watch you. We need to make sure that you're doing okay. He kind of said, no thanks, and left against medical advice and jumped on a flight home. Now, the physician in Chicago contacted the physician in Dallas, saying, hey, I have this patient and I'm actually worried about him because he left AMA and I want to know what's going on with him. So the physician in Dallas started calling the patient. And this was kind of pre-cell phone. So it was an answering machine at their house that they got. And the message on the answering machine said, thank you so much for calling. Your thoughts and prayers are so important at this time as we deal with this, medical tragedy, something to that effect. Turns out that the patient was admitted to a local hospital in Dallas with meningitis, and then developed bilateral blindness, cortical blindness, secondary to a bilateral uncal herniation. And the thought was that the patient developed increased intracranial pressures, which led to herniation, which then led to a posterior cerebral artery infarct. Now, again, crazy story. Likelihood of this, let's be honest, very, very low. But a complication, but actually you can see how in this case, the physicians really, really tried to do everything that they could for this person. And unfortunately, his bravado or whatever you would call it, kind of led him down a path from which he couldn't recover. Now, interestingly enough, obviously this person could never fly again, but he became a fairly successful advocate for the blind. He sort of found something of a new calling. So he was a really interesting guy who took a tragic situation and really tried to make the best of it. So last thing I'm going to leave you with, and this is one of the things that I think about, again, when I think about complications. I have a checklist, and I have adopted this from other people's checklists. I've made it my own. This is by no means complete. It's what works for me on a day-to-day basis. So I have this on paper, okay? And I bring it into the operating room and I stick it up there and I go through these things just to make sure I'm not forgetting. And, sometimes I say I do this for the residents to teach them. I do, but I do it for me too. It's helpful for me. We're all busy. We're all thinking about other things. And, what if I missed that anode cell? That's a bad thing. So just to go through it, these are the things I'll do beforehand. This is on me. This is the surgeon. Make sure that we have the right CAT scan. Okay, make sure it's the right side, right patient, right date. Is the image guidance working if we're using it? And then let's look at some of these anatomic variations. And these were really the things that we went through earlier. And so I will go through these. Is there skull base erosion? How's the lamina look? Is there an anode cell? Where's the anterethmoid artery? Is the carotid intact? where's our uncinate process attached? What's that posterior ethmoid height relative to the macular sinus? And then any of our other cells that with which we're interested. All right, next. This is with everybody. We have to do our timeout. We have to confirm the patient and all that kind of stuff. But then the things that I want to make sure of that we have, our topical anesthesia, is it stained? Again, I stain it with fluorescein and labeled. The injectable anesthesia, is it labeled and left unstained? Do we have cautery materials, suction cautery, bipolar? Are those available in the room? I don't want somebody to have to go running for them. I want them around. Do we have hemostatic materials, Fibrilar, Surgicel? I don't need it all opened. I just want to make sure it's available. And have we talked about specimens? Is there a sock on the microdebrider? What are we going to call our specimens? Things like that. And then lastly, before we're done, are our pledgets correct? Have we documented anything that we left in there, like any stents, spacers, packing? And then again, did we get our pathology correct? And then I'll sign this, and then it gets scanned into the chart. Now, again, I don't do this for medical legal reasons. I have no idea if it would cover anything there. It's not why I do it. I do it to help me. I do it to help me. I do it to hopefully help the patient. So it seems like a lot of work. It is nothing different than you typically do every day. So again, it works for me. If it's something that you're interested in, I think it helps to tailor it to your workflow. Okay. I just want to say thank you for the invitation, and thanks everybody for their attention. I really appreciate it. These are crazy times. And so it's actually fun to be able to kind of get back to a little bit of some normalcy and talk about the things that we typically talk about instead of, COVID-19.
Thank you. Thank you very much, Peter. Very, very nice talk. As you know, I was watching your pituitary and carotid injury. I was talking to Dr. Paletti here, my colleague, who's a base of skull surgeon. And us ENT surgeons tend to be humble, and I think that's a good thing. But I was operating with a neurosurgeon. This was like probably 10 years ago on the pituitary, and I noticed that he left the hospital. That's why I could talk about it. But I noticed that he was just too aggressive. So I was just asking him, so he was looking at me like this ENT surgeon who doesn't know what he's talking about. And then this all hell broke loose, as you had seen here. And even with that, I did exactly what you did. And even with that, he wasn't convinced. No, this is not the carotid. He's just a shaky ENT surgeon. And anyway, we packed, and we took the patient for the angio suite, and the patient did have a pseudoaneurysm in the area. We had to take care of it. But I really think, this is, we most people view us as, humble surgeons, and I think that's a great thing. Sometimes the big guys, neurosurgery and stuff, tend to be too sure of themselves.
Well, it was funny. I had the two neurosurgeons I work with, thankfully, are a little bit more on that kind of humble side, which is great. The funny part was the person who did the angio, who's actually he's very good and he's very nice. And I wouldn't, but he was kind of like, it's not a big deal, da da da. And he did the angio and he said, I don't think that's carotid. And then I showed him the video. I sent him the video via text message, and I got the text message I got back said, "Whoa, baby, that's real. I was wrong."
Great. So, Peter, can I ask you to take a look at the chat lines? There's quite a few questions. If you could scroll through them, and thank you.
Absolutely. Okay.
There's a lot of social conversations as well, but
yeah. So. One of the questions is, what's your advice on operating with images on a computer screen? If printed, you are able to keep referring to the pictures. I think that's actually a very interesting question, and that's something that I've had to adjust to. When I trained and in the very beginning of my career, we had printed films, and they were always up, and I could always go look at them. And I don't have that anymore. It's nobody wants to print films, and so I've had to adjust. And so the thing that I'll do is, as best I can, keep some sort of towel on the mouse, so that I can just scroll through the images if I want to, and that will at least give me that kind of dynamic look. But I think that was certainly a change to me. But having that whole picture out was always kind of nice to me, and I've just had to adjust my brain to that. Somebody asked about acellular dermis. I'm sorry. The product that I was referring to specifically is we use a lot of alloderm, so a synthetic tissue that's it's cadaveric dermis, and that's what we'll typically use for our larger leaks. Let's see. Do you use glue with the other techniques to repair CSF leak? Not typically. But I will at times. Sometimes if it's in an awkward position and I'm having a hard time getting it to adhere as well as I want it to, I will use some degree of glue. The neurosurgeons that I work with do like to use some sort of tissue glue for pituitaries and things like that. So I find myself using it there at their preference. Another question. How long do you keep a patient with CSF leak on admission? That's a great question. So the way I will typically do it, if it's an iatrogenic leak, if the next day they are not leaking, I will tell them that they may go home. Most typically, they would like to stay another day, and I tend to be fine with that. But if they're okay the next day, I do let them go home. And that's honestly the same thing I do with spontaneous leaks. So, is it ethical to operate on a patient for a CSF leak repair without consenting them? Well, that's another great question. I think in some respects, I have hopefully I have had the discussion with them that if this complication potentially happens, it's something we will fix right there. I have never had a patient be upset that I fixed it at that time. I would not feel right waking them up, then discussing it with them, then going right back to fixing it, when at that point I could fix it right there. I do think it's ethical because my overarching goal in doing that is to aid the patient. So. Let's see. You mentioned some vitamins. Vitamin E that can cause more bleeding. Vitamin E is the big one.
So I'm gonna stop this. I'm gonna stop this here. Thank you very much for joining us. We're going to be working over the next few weeks on having a lot of live transmissions from bigger departments in the United States. We were going to be conducting grand rounds at Weill Cornell Medical Center in New York City, and we will be transmitting those through our website. So I think there's a lot of stuff coming up. Please share the links with your friends and colleagues, and really enjoy seeing you guys every evening. You have a nice evening.